This is the introduction to our first of our ethical sections. And I just want to say, when it comes to ethical matters, things are not always straightforward. And somebody can have a very strong opinion in one direction, and somebody can have a very strong opinion in the other direction. What we're trying to do today in our two ethical sections is to give you some background and some thought, thank you so much, some thought material which will help us to think these things through as a child health community and see where we may change our own thoughts, where we need to think about the balance between one view and another, and what is right and what is more right than something else in terms of what we need to do. So we've chosen essential medicines as one of our sort of hot topics where we really have a lot that we need to think about as far as access to essential medicines for children is concerned. I've made a little list of the medicines over the last 10 years, and a lot of them in the last 5, that have either disappeared or are difficult to, they come and then now we're having to do section 21s in order to get a medication. Something like phenobarbital injection, which is a critical medicine for stopping a child having a fit. If you can't stop a child having a fit, they're likely to end up with brain damage. Chloral hydrate. Now, it doesn't have a huge science behind it, but for those of us who've used it know it's often a very gentle way to get a child to sleep in order to do a procedure. Flucloxacillin syrup. Staphylococcal infection. Very effective, well absorbed. Not available because no company in this country is actually making it. We'll have a detailed look at benzathine penicillin. Valeron drops. Gone. BCG. We had to search the world to try and find BCG. For our obstetric partners, ergometrin to stop PPH. Disappeared. Phosphate solution. One of the 10 steps. We have to write a section 21 in order to give that to our sickest children. Ampicillin injection. Our commonest use for a child who's being admitted to hospital for pneumonia. Very tentative supply. We had to try and work how we were going to do that. Ciprofloxacin syrup for dysentery. Comes and goes. Colistin for our very sickest children in hospital. An essential medicine, but again, section 21 every time we want to use it. And penicillin VK. Very essential medicine. I was in Canada not so long ago, and they have to use amoxicillin because they can't find penicillin VK because none of the companies in their country actually make it. And MAN2 solution, we know about that. So that's my introduction, and that's why we felt that it was good to have this discussed. So I'd like to welcome somebody who's had a lot of experience in thinking about that, and that's Professor Mariana Kruger from the University of Stellenbosch. She is the head of department, the Tygerberg Children's Hospital Department of Pediatrics, and also for the University of Stellenbosch Department of Pediatrics. So welcome, Mariana, and very, very privileged to have you here.
Good morning, ladies and gentlemen. First of all, I want to thank Tony for putting this conference together, and together with Elmry and the team. This is such an essential part, and I have to apologize for not attending, but due to unforeseen circumstances in my personal life, I wasn't able to come Thursday and yesterday. And I'm very glad to talk about this topic because I think many of us are passionate about medicines for children. We want better medicines for our children. We want to make sure that it's safe and efficacious. And to just, I have to say this because I am funded by the NIH for ethics, and so this is my personal view and it doesn't represent any other party. Just an outline, I'll briefly talk about unlicensed and off-label medicine use, which is very common in pediatrics. Ask the key question is how do we improve access to better medicines for children, and I see that as our ethical responsibility. Just a few words about the EDL and the orphan medicine list. However, later on you'll hear more about the EDL. Look at the USA and European Union, what they've done and what I think we should be doing in South Africa. But as an introduction, I just want to draw the attention again to the mortality for under 5 children, and we can see that 41% are neonatal, and 59% are children. And we know it's diarrhea and pneumonia as the most common ones, but I just want to draw your attention because my other passion is rare diseases and getting access to care for rare diseases, that non-communicable diseases are causing 4% of all deaths, which is even more than AIDS at the moment at 2%, and this comes from the WHO webpage. So we have to also remember not only the common conditions, but also the rare conditions. Just for the sake of definitions, off-label medicine use is usually when you cannot find it in the package insert. It can be for dose, frequency, age, and formulation. And unregistered or unlicensed means that it's not registered in the particular country. In our context, we use unregistered, in the US, unlicensed. Now, why do we have this practice? It's mostly because we have a lack of pediatric clinical trials, and we know that it is our practice to go and take what is working for adults and then extrapolating it by children, and usually how we do it is by adjusting the body weight, scaling down from adult dosages, which is not really appropriate since we're all scientists and we have to find better ways of making sure it's safe for children. And this is just a very busy slide, but it's a good review of all the studies published by Kimland and Otland in 2012 about off-label studies for children in hospital, and one can see that it ranges for neonatology between 65 and 55% of off-label medicine use versus the rest of inpatients between 18 to 36%. So it is a common practice, and one could say that about a third of all children in hospitals will have at least one off-label medicine episode per drug event. Same goes for primary care. I mean, I think I just want to draw your attention to the last line where they nearly looked at a million children's scripts and found that 13.5% of them were off-label. And it just demonstrates how big the problem is. Now, a study that Yashna did, Kubal, for her MEd in our context, where she looked at off-label medicine use in highly specialized pediatrics, she found that 41% actually, of all events in these children were off-label, and the most common reasons were dose, extemporaneous, and age. And we all know that we don't have pediatric-friendly formulations. And you just go to TB medicines. Most of them are extemporaneous. Same goes for some of the HIV/AIDS medicines. It's just interesting, and this is, if you compare between a TB and HIV, it's far worse the off-label use in TB because there were not that many clinical trials. And I mean, there's been all this big trial for HIV clinical trials, so that is not as a huge percentage off-label. Now, taking the Convention on the Rights of the Child for this talk today, we know that and these are the three articles that are dealing with healthcare in children, but specifically Article 3 will say that you need to ensure the existence of institution services and facilities adequate for healthcare. And I put in brackets there, that means also safe and efficacious medicines. So we have to make sure that we do something about it. So what are the questions? Is it only for the burden of disease? And I want to say that we do have a burden of disease of TB and neonatology problems, but we should not in the process forget the rare diseases. That is why I leave this question there. And then we also need to remember there are conditions that only affect children. And the next question is then, how do we get them better access for all children? And what is my individual responsibility? Because when I'm doing ethics, it's my responsibility that I'm talking about, not the world out there, but what should I do to improve it? Now, we know that there are currently two approaches. The one is the essential medicine list or the essential drug list, and the other one that is mostly in the US and in Europe is the orphan drug list, which are for specifically rare diseases, and I've just given the definitions there of rare diseases. We know that the WHO established the essential drug list in 1977, and it was there to be a normative guideline to have essential medicines available to make sure that children do survive and that we do improve their health. And the key concepts were that it should be available, it should be affordable, it should be of a good quality, and it should be appropriately used, and it should be cost effective. Now, in a sense, that means that all medicines that have been proven for a particular condition can actually be included in the essential drug list. That goes for both common and rare diseases. I know that most people usually talk in terms of common diseases. Now, I'm a pediatric oncologist by training, and cancers in children are actually rare diseases, and we have been successful driving the process of getting medicines on the essential drug list for cancer treatment, which I will come later to, which is very important. Now, to be able to get it on the essential medicine list, it is important to make sure that it's cost effective, so a cost effective analysis must be done, and when that has been proven, it can become a high priority for a rare disease and should be included in the EDL. So that is one advertisement that I'm doing for the rare diseases, because we can't only focus on the common, we also need to think of our rare diseases. Now, the US and the European Union went a different way, and they've created in the US the Orphan Drugs Act, and the EU has followed suit in 2000. And there they look at the prevalence. It's really where it's very low disease incidence or prevalence, where it's very chronic or debilitating. And they look then at effective treatments that are available. They're looking at safety profile, and they do huge studies to try and get that. And there's quite innovative clinical trials that you are doing, where you give the medicine to the child and then you wash out the period and you give a placebo to the same child, because you can't do the classic placebo-controlled trials as in where you have large numbers of diseases. So there's innovative ways of doing clinical trials for them. Then they look at how to get it available as well as affordable, and the diagnosis obviously must be feasible, and it needs, unfortunately, expertise infrastructure. Just a comparison between the two, EDL is usually more for public health, whereas often drugs are more for the individual patient. EDL is medicine-driven for efficacious, safe, cost-effective, and evidence-based medicine, whereas for the orphan drugs, it's really driven by the disease, and it's usually the rare disease, and it's mostly for the new medicines. And at the moment, unfortunately, mostly available in high-income countries with a high price per individual patient. Now, in order to make sure that children have better medicines in the US as well as in the European Union, both countries created a regulatory framework to address this issue. And they started, since the 1960s, we are aware that we don't have enough outcome-based evidence for medicines for children. And so they started saying, well, let's look at ways of doing it. And so the US started first by having two acts that they promulgated. The first is the Best Pharmaceuticals for Children Act, which they said that they will give additional market exclusivity to a sponsor if they also include pediatric study results when they try to register or license the drug in the US. And that is actually quite a carrot to these companies. And this was followed by the Pediatric Research Equity Act, where they said if you have now new or certain approved medicines, you must investigate them now for the potential pediatric benefit. And in order to get your application through, you must have pediatric study results unless the FDA allows you to waive the need for pediatric results. And this is mostly for conditions that only affect adults, such as bronchocarcinoma, really adult onset diseases. Now, since they've promulgated these two acts, more than 500 medicines have changed their licensing and are now available for children. So this is really a very good example. The EU then in 2006 followed the same with a pediatric regulation, where they created the pediatric investigation plan, and sponsors now have to add the pediatric studies to when they try to license the medicine. Unfortunately, this had a very negative effect on certain, again, diseases like cancer. And I'm going to give this example because in pediatric cancer, what has now happened is that these pediatric investigation plans are actually being driven for the new medicines by the adults' needs and the adult cancers. So now you can get treatment for a very rare cancer such as melanoma. It's very rare in children, it's mostly in adults. And you have all the medicines available. But neuroblastoma, which is only in children, has nothing new coming. And so this also, in a sense, sponsors or the pharmaceutical companies start to drive the process looking from the adult perspective still. So they will still have to do something in this context. And this is our challenge as well, to get children onto the agenda of pharmaceutical companies, even specifically for those diseases that are only affecting children. So, what is the current status in the low and middle income countries? Because this is where we are dealing with it. We are living here in a public health environment where we make sure that we implement the essential drug list. So, and this is mostly for common childhood conditions. And if we are then dealing with rare diseases and we have the evidence, and this is specifically true for childhood cancer, we need to make sure that these medicines are added to the essential drug list. We also deal with private health care in this country as well as the rest of Africa, and there to a certain degree they also follow the public health model, looking at the essential drug list, and specifically in managed health care they want to see the evidence before they allow you for a specific treatment procedures, and you have to be able to motivate it. So clearly evidence is what we need. And so for this reason, I just bringing this slide in coming from our own background. We started with a drive in 2000 in the International Society of Pediatric Oncology of trying to get access to care for all children with cancer in the world, because we know 15% of the world has access to 85% of the medicines versus 85% only access to 15%. And we started getting the medicines onto the essential drug list, and it's really the cheap ones like vincristine, prednisone, cyclophosphamide, adriamycin. And then we divided the world into settings. Low income is setting 1, middle income is setting 2, and high income is setting 3. And I've just returned from Cameroon where we are testing the treatment of, I'm testing the treatment of retinoblastoma in a low income setting, and already the results look like more than 50% of the children are surviving. My colleague has been doing that for Burkitt lymphoma, and he's achieving now close to 70% survival. So that is really good, because these children are going to grow into adults. So this is the kind of thing that we need to drive, is to make sure that if we're dealing with diseases and it's not on the essential drug list, we need to get them onto the essential drug list. And of course, we have to become partners with the WHO to do that. Just taking this further, because we all talk about cost effectiveness to get it onto the EDL, and we've looked at our treatment protocols, these modified treatment protocols for leukemia in Brazil and Burkitt lymphoma in Malawi, and one of our very bright colleagues, Bhakta from Toronto, worked out the cost effectiveness using the WHO model, looking at the disability life years prevented compared to the GDP of a country, and it's less than a 1-to-1 ratio, then you know it's cost effective. And for both these diseases, it was extremely cost effective. So this is the kind of thing that we need to do, that if we know about effective treatment, get it onto the EDL and work out, and make sure that you prove that it's cost effective. So in conclusion, what do I want us to do? I want to say that as we all sit here, we are all prescribing medicines off-label. We know we are doing it. It is a common practice. It is not illegal. It is what we have to do. Medicines are the tool of our trade, and we have to use that. But since we are doing it, we need to start publishing our evidence of what was effective. And even the case studies should be published so that we can start generating evidence specifically also for the rare diseases. But on the other hand, we are using off-label medicines, and we also need to start publishing when we have adverse medicine events, because we need to know, is this safe, is it not safe? And we also need to publish our negative results. And it's really a pity that I think we are all over the world repeating studies that have proven to be futile. But because it hasn't been published, we keep on doing it. So it's in time that we start thinking about publishing that. And then my fourth point is to really start saying, listen, we are pediatricians. Let's come together. Let's work collaboratively together. I mean, one of the medicines that was on Tony's list was ciprofloxacin. We all use ciprofloxacin. We know there's no pediatric data. It is time that we all together say, well, let's just make this a clinical trial. This is anyway our standard of care. Let's work together, let's generate the evidence, let's get it published, and let's prove that this is safe and efficacious for children. And we know that in ICUs, they use a lot of ciprofloxacin in certain neonatal ICUs long term, and I haven't seen a lot of children with bone problems, which is a great concern. So it's time that we start doing this, but we should do it in a scientific and systematic manner. And I would want to close by saying it is truly our ethical responsibility to start advocating for better medicines. And this is the interesting thing in South Africa, and that goes in the US and so on too. If you think you have the evidence for a particular medicine which is not registered for pediatric use, and you think it should be registered, you can approach the MCC by yourself and say, listen, can't we start looking at this? Here's the evidence. But before that, of course, before we can get to the MCC, we have to generate the evidence, which come back to my previous bullet point. So let's start acting together. Let's start thinking of how we can generate the evidence and then go to the MCC and say, please register this for pediatric use. We are anyway using it. It is safe. It is efficacious. Here's the data. And with that, I want to thank you for your attention.
Professor Kruger, thank you very, very much for setting the scene of actually what a lot of work there still is to do to make medicines safe for children and accessible to children. We're going to take a particular example now, and I'm very pleased to invite Dr. John Lawrenson, who's the head of pediatric cardiology in the Western Cape, and he's going to take a particular example and give us a global perspective on advocacy for an essential medicine. So John, please come up. Thank you very much.
Thank you very much, Tony, for the invitation. I'm going to tell you a little bit of a story today. It could be dramatic, it could be seen as the small man versus the big man, the curse of big pharma, etc. But it's actually none of that. It's just a very complicated story. Imagine a 24-year-old patient from somewhere in Central Africa. I'm going to call her a she, and you'll see why. She has mixed mitral valve disease. Her symptoms are controlled with diuretics. She will never ever get access to surgery, and she arrives at a clinic for monthly intramuscular penicillin injection, and she's told there's a stock out. I always thought stock out was a South African term, but I was pleased to realize it was a worldwide term. Now, let's put the patient in context. That's the drug she needs, the benzathine benzyl penicillin, which has been around since the early 1950s. And she needs that medication. It's part of the WHO essential drug list. Thanks to my colleague Liesel Zulke, we know a lot about patients with rheumatic heart disease in Africa nowadays. And this publication from just a little while ago detailed a registry collected over 2 years in 15 African countries, Yemen and parts of India. And it showed that rheumatic heart disease is really a very devastating disease, and it's still present. And you can see that they managed to find 3,000 people. These are hospital admissions in a 2-year period, and you can see that the age is somewhere in the 20s, the sort of median age. Anyway, and she also looked and she divided them into low income, low middle income, and then upper middle income, which was us. And you can see that there's much more access to surgery where we live, as opposed to places like Uganda, and there's also more access to interventions for mitral stenosis. Paradoxically, the patients get their prophylaxis for intramuscular penicillin. They get more prophylaxis in the low-income countries, which is a good thing because they don't have surgery. Then she went and followed up a 2-year survival, and the results are absolutely horrible, because 20% of the patients had died over the period of 2 years. And the median age of death was about 28 years. So these are young people dying from a preventable disease. So why does our hypothetical patient need benzathine penicillin? Well, she needs benzathine penicillin, and it's been known for a long time to stop recurrent attacks. And this is just a graph from, which I've highlighted at the bottom, from a Brazilian paper, showing that the development of valvular heart disease is directly related to recurrences of attacks of acute rheumatic fever. The other thing about that is that it's been known since the 50s that intramuscular penicillin reduces recurrent attacks by up to 90%. And this was a meta-analysis that Bongani Mayosi was the senior author on, showing that it's been known for a long time that intramuscular penicillin is better than oral penicillin at preventing further attacks of rheumatic fever. And you can see there are many various guidelines all over the world, and our guidelines say that you must carry on with intramuscular penicillin until you're at least 25 years old. But for people who have valvular heart disease, people need intramuscular penicillin their whole life. So why can't you get intramuscular penicillin? Recently, this publication was produced by a thing called RHD Action Alliance. Now, RHD Action Alliance is a composite force, relates to the World Heart Federation, which is the amalgamation or the trade union of all societies related to heart disease, professional societies related to heart disease, Medtronic Foundation, which is the charitable arm of Medtronic, and then an organization called REACH, which is a think tank. Based in Australia, but Liesel Zulke in Cape Town is the other co-director, and she lives at Red Cross, where all sorts of policies are about rheumatic heart disease and their aim of getting rid of rheumatic heart disease are put together. And they published this recent publication called Global Status of BPG Report, and it's available on the net, fairly easy to find. And in there, they go through the whole detail. Now, there are two major formulations of benzathine penicillin. On the far side of your slide, you can see that there's the powder version, which is the common version, and the cheap version that most of us are aware of. And on this side is the liquid penicillin, which has to be used with a cold chain. Now, the major indications for benzathine penicillin, there are only really two. The one is the treatment of syphilis, particularly in pregnant women. Okay, so as you're all aware, congenital syphilis can be a devastating disease. And then the other one is the prophylaxis against rheumatic heart disease. There are lesser indications, which you can see is particularly the treatment of the tropical treponema infections. And those, there are alternatives like azithromycin. And these other indications are a little bit softer, but the two hard indications for the drug are right at the top. Now, although it's an essential drug, it suffers from the fact that there are very relatively few places in the world that make it. And it also suffers from the fact that it's actually quite a complex manufacturing process. If you look in the middle of this graph, there's API and sterile API, which is active pharmaceutical ingredient. And it's hard to believe, but all the benzathine penicillin used in the world came from 3 factories. And then one of the factories got closed. And that factory was in China and was inspected by a French drugs agency, and they found that they were making unsafe penicillin. So there are only 2 agencies, one in China, one in India, that make all the API for everybody. And that is then formulated by various other manufacturers. It's everywhere, it's a generic. So it's a very complex problem without an obvious solution, and I've listed a number of the reasons and highlighted one of them, but I'll just briefly go through them. It's an old product. For instance, in the United Kingdom, it's not even registered. And in places where it is registered, it's very difficult to get the past of, as we talked about, anecdotal use in the past, which would, like chloral hydrate, it's very difficult to get past that. That's how it was put together. And so it's difficult to reformulate. So it has lots of problems, but it's difficult to get reformulated. Then there's regulation, which varies from the sublime to the ridiculous. So you have the sublime with no regulation, which is I suppose one way of looking at it. And then the ridiculous, which is parts of India where concern about anaphylaxis has resulted in the drug being restricted, which is really quite paradoxical. And then talking about the response to anaphylaxis. Anaphylaxis to benzathine penicillin is very, very rare. What's more common is vasovagal syncope, because it's a huge needle with a huge amount of liquid, and it's very, very sore to give, or very, very sore to receive. And so a lot of people who said to have anaphylaxis have only fainted, and this is one of its problems. Talked about the pharmaceutical ingredient manufacturers. The other thing that they talk about is poor visibility of demand, which I didn't understand until I read a little bit more. But for something like, for instance, syphilis, it's epidemics of syphilis are not there all the time. there's an increased incidence of syphilis, then it drops off and it comes up again. And similarly with rheumatic fever has only become a more visible disease recently, or rheumatic heart disease, where people have gone into populations of children and looked for subacute disease. So it's very hard to predict, and you get funny demand. So, for instance, there's an anecdotal report of the United Nations urgent request to produce 100 vials of penicillin. So the demands are very, very small. Whereas for syphilis alone, it's estimated that you need about 5 or 6 million doses per annum. The other thing is that we all want cheap prices, but the prices are actually too low. They're too low when you're looking at 22 to 23 American cents per dose. It's too low for a factory to carry on making economically viable. And we've talked, the markets are very, very fragmented. They're all over the world with different needs. So are there solutions? Well, that report puts together a whole lot of solutions, and I just highlighted a few of them. One is to map the stakeholders, so know who uses the drug, who needs the drug and who uses the drug and who prescribes the drug. And then the other thing is to create alternative plans when you get anticipated stockouts. So we've had a couple of shortages in South Africa, and there have been ways of getting alternatives. My colleague John Masuku, who works in Zambia, he had a problem of no penicillin, and he eventually went to Novartis and said, please make sure I can have penicillin. And they've got that sort of solution. And then penicillin is a WHO sentinel medicine, so there's a lot of engagement to stabilize the supply of penicillin among other essential medicines. And then, of course, there's trying to develop alternatives. And just to end with the alternatives, this is a publication trying to show what would be a better drug than intramuscular penicillin. So to give a depot formulation that's not too long so that people forget to come back, but not too short, that's not painless, that's subcutaneous, and that doesn't need a cold chain. So that's the kind of way one would hope research would go. Thank you very much for listening.
Thank you very much, John, for unpacking a single case for us to give us some idea of the issues that come up. And I'd very much like to invite Professor Marc Blockman to the podium. Professor Blockman is Head of Clinical Pharmacology at the University of Cape Town and has vast experience in various ways with medicines, essential medicines, MCC, etc. So we're very privileged to have him here. I'm very, very grateful, Marc, for you giving your time on a Saturday morning, as with the other speakers, to be here to speak to us. So welcome and thank you.
So good morning, everybody, and thank you very much. I look forward to the panel discussion. I've heard a lot of discussion earlier around essential medicine, and I was alluding to that in my presentation. But I think it also would be valuable for me to wear other hats as well, because there's some top-notch hats, as well as the pharmaceutical advisor connected to the pharmacist, as well as the private sector. So I think there is a connection between the two, and John has highlighted the So I'm going to race through these slides because I think it's the principles which are important, and then whatever questions come, we can kind of deal with. And I've got lots of conflicts, and for a small fee, you can get them from me. So just to say that we are protected by Section 27 of the Constitution, the great Constitution. It's worthwhile reading it. How many in the audience have read the Constitution? Don't worry. So, you're not going to read this one. Very important Constitution. Autonomy and respect for persons very well. And the right act in Section 27, which looks at right. Well, the problem with that is that when a human being is got the duty to everybody to provide the basic right. And as you remember, what we had, you can't tell them what the basic rights really are. So you may not actually kind of be able to provide complete healthcare to everybody, but we should be aspiring to the best healthcare possible. And then obviously everybody has the right to healthcare, and ensure access to quality and comprehensive healthcare and medicines, which is kind of what we're talking about at this moment in time. So the National Drug Policy is a critical document. It's being reviewed 20 years down the line to make sure that it's up to date with the National Drug Policy in terms of access of healthcare and access of good quality medicine to our population. That's what underpins the National Drug Policy. The Essential Medicine List program is part of that process. It started with primary healthcare, again moved on to an adult and a pediatric secondary level, and there's a tertiary maternity DL committee, which looks at obviously academic medicine, with oncology for kids where the advocacy is actually required, and it sits within the national health policy. And so basically we're looking at access. It's very important. It's like a bandied around word. What does access really mean? It's worthwhile kind of getting a definition from this group. What is really access? Quality, at least in our country, we can kind of guarantee maybe 90% of our medicines, the ones that don't break in the bottom of the container, quality, most of them release our tablet formulation, release in the body to get to patients, and then rational medicine use, making sure that you use drugs appropriately for the correct person. Cost effectiveness. So I don't think we practice cost effectiveness in this country. And I'll tell you why we don't. Why we don't have the data. We don't actually have the data until the outcomes in our overall data. We don't have the data. What about patients? We don't have the data to decide if a substance is cost effective or not. Whether it's involving data utility that is required to say that it's right exactly. Most people say dialysis. Well, many people do dialysis, and it's not really hold up 200,000 rand for life adjusted here. We don't actually know what the cost effective in our own country. The other issue with affordability is we're discussing about affordability, we upscale. So we must be careful about the word we use. Have proper definitions, and we can actually aspire to cost-effective healthcare. The essential medicine is basically to satisfy the priority of healthcare needs of the population. And I think that's quite important. So we're missing the priority. People should be advocates around that. This is important, and if you move out of the Western Cape, and excuse me if I tread on toes, the access is not great. And so we're a bit of a jaundiced understanding of health access in the Western Cape, especially on the road. But basically, that's what the promise is. The Essential Medicines List and the National Drug Policy promises that. So because it's a promise, we should educate our patients to aspire to turn people off if they're not getting the kind of good quality of care that they actually require. That's what's very important. By the economy and the capacity to do so, I don't think this is right. And I think it's applies to the individual community forward. It's worthwhile talking about that, because one can debate what, the price of not giving something, the opportunity cost is very high. The EMO is forward-looking, incorporating the needs in terms of updating, that's a regular update because evidence changes, formulations change, new drugs come on the market, trying to respect the physics of the country going forward. And the idea is to try and get better medicines, if there are better medicines, and in antibiotic stewardship, which is very important to understand the resistant patterns of the country. There's also, which goes to the EMO, is standard treatment guidelines. And standard treatment guidelines, I think, instead of having a list, the list is just honest. You put a list and say, well, this is what we should do. That's why incorporating standard treatment guidelines allows people to interrogate the evidence. There's a clinical decision-making and a rationale of clinical government around the use of the medicine. I think it's quite useful in the public domain, and then say, well, we don't agree with that, number one. So if we don't agree with that, we don't need the treatment. That treatment should be done with EMR. The opportunity is not only to change the methods as well, but to change the standard treatment guidelines. The other issue is obviously the EML. If we think it's all correct in terms of a standard treatment guideline, we think it is appropriate because medicine is not a recipe, then it may prevent irrational medicine use. And for me, irrational medicine use, one is cost. But for me, it's very important. In fact, adverse events. People do not like talking about adverse events. Our population is in fact having an adult unfortunately, and we will continue in 5 hospitals. 8% of the time, 8.3% of the time, people come into the hospital with adverse events of the drug. In other countries, distribution was 5.8 to 6.1. terms of irrational medicine use. And there's no ICD-10 coding for harm. There's no ICD-10 coding, so people just don't really code that. I put this up here because in the public sector, we have PTC, pharmaceutical advice committees. In the private sector, all the ordinary development teams have to have clinical evaluation and studies. In our public sector, it's called the PTC. You have a responsibility. You have a responsibility to make sure it's active. But there's another environment in our own provinces to keep people accountable for their access. I think that's selection here, for the access of medicines for the population as a conduit, as part of the advocacy process going forward. So what is the program? This is the Essential Medicines, in fact, the Essential Medicines program. We'll talk about it, you can ask for this. The program here, which I'll show you a slide, it keeps moving tending it. The bottom line is medicines aren't in the EML, they will not be tended for. That's a massive issue. It's a massive issue for you guys who are in the audience who are going to advocate for medicine. If the right isn't on the EML, it's very hard to tend it because you need a buy out and the company can decide whatever they want to charge for that medicine then becomes affordable. So one of the issues is to motivate, to really go to the place of medicine, which is a shift, that's to motivate. So essentially, the affordable medicines director and then obviously the chief director. There's a whole governance process which underpins access to healthcare within the state sector. Here's the national EML, and you'll see that there's a primary healthcare group, and at the end there's a pediatric hospital expert group. I can give you their names. Sorry, I understand. So read the books here. Of like-minded people, one of the main stuff, make medicine, instead of available in our country, obviously, make medicine available to the population. And then you see the tertiary healthcare group as well, which may talk to some of the kind of rare disorders and the extraordinary disorders, as long as the medicines are there. The selection, this is very important. I'm not going to go through it very quickly. Is that the selection process is very hard. It's very hard to get a medicine on the email. I'm actually telling you that now. But people take it very seriously. The evidence that is required, as best as possible, often is advantage of our people saying that. The evidence that is required is very low. One cannot just say because we've used it before and there's a couple of abstracts. And it's actually required is a good governance process that's robust and sustainable. You see, if you don't actually make a mistake, and it's like this is on the agenda, and it's issue. Number 3, one is the expectation. 2, the manufacturers will introduce a legal challenge around the fact of what evidence you do. Thirdly, the private sector. It's importantly the private sector hold up as a prescriber of benefit, what is involved, what we provide in the state sector. If we don't provide in the state sector, we haven't got advocacy, there's a good chance that people are discovering or saying, sorry, if you're not in here now, you cannot get the medicine. So in fact, it's a continuum. We have to make sure that we do due diligence to getting medicine on the EML to provide access across the board to our population. And as NHI goes in, the EML will be actually the formula for the whole country. The EML will form the formula for the whole country and what will take at least primary and secondary level in both private and public. So as you can see, there's a whole issue with the principles. I put up the principles again because it's very challenging, and you about having a procedural issue to challenge if there's a problem in terms of access, but there's a governance process to where people can challenge. So this is sometimes people wobble on evidence. When medicines are registered, most manufacturers only use them in clinical trials. Unfortunately, those clinical trials are not good for your everyday world example. There's not comparative studies that are using drug regulatory evidence. Most of the companies do to make decisions on what the industry wants to provide you with. And so often there's a vacuum in terms of you can have these slides with pleasure. Okay. So if I just show you an example, and this is a personal example, because I began like this, oral formula. And I'll just show you how critical it is. And you'll see that if you look, just look at this. Don't worry about that. Just look at this. You'll see that basically, if we get the price of the course, it's almost 16,500 over 3,000. So you will say, well, 3,500, come on. 3,500 rand. So it's probably 3,500 rand. You pay for me, and then 150 more. You're looking at 14 million people. That's almost 18 million rand extra. And so what they will do, they throw on the side of the cheaper aid, obviously evidence like we did, and this 3,500 rand over here, which looks meaningless in terms of a greater scheme, is very relevant in terms of its affordability. When you look at the numbers of people that need hence, value and hospital becomes a problem and unaffordable in the South African circumstance. So you end up having people end up having to come back and 2 times a week getting of gang hospital. One of the examples of the hard and the difficult decisions that are made at national level becomes a very important agent where issues. So price negotiation needs to happen. We need to make sure that the director, the chief director out there, in the country, like Lawrenson and Marc Blockman, you go and discharge patients home, when they're stable, on oral agents, they don't have to come backwards and forwards with public transport to come get an intravenous infusion. Okay. So here's the budget. So this is, you can either get those chocolates or you can get these chocolates. And I've actually put this up on purpose. Because it's worthwhile having the discussion, because if people say, should we have a Mini or should we have a Rolls Royce, whatever else, it's not as easy as that. It's not about picking chocolates. But this is a common example that people have. Do we need those 45 rand chocolates, or can we get away with these chocolates over there? Okay. The other issue is, what do we think? What is the evidence base that is actually used? And I'm not going to put up hierarchical, but especially the Excel definition of ABCD, that's very common. Okay? And you look at the grade of evidence, grade A to grade B, I call it grade B evidence. Desperate. Okay? It's desperate that you actually believe that. There is no infection cause in Joga, you will not accept that. Often, that's very controversial, because you just do that, okay? To not say so. And that's not the thing, and you are looking at slightly different process. That's not really why this information, okay? Those nice glossy pages that we're getting, the gloss of the structure. Randomized control studies against switch it over. We are looking at the highest level. Impossible to make a decision. And I agree with you. There are bad systematic reviews and bad meta-analyses as well. But we're trying to get to what the effect size is, and can it be transparent? Is there a transparent process in terms of the decision making? Okay. Yeah, you've seen this before. I've just mentioned that. These are the booklets. All our apps. Different books. It's made available. STGs are available on an app. You can download it, and you don't need internet to actually utilize it. So it is free available. And the other issue is the provincial PDC involved in the EML process. The province can't say, by the way, the EML sits over here and they make decisions. They're actually involved. There's representation on all the PDCs and the EML. So the issues in the provincial section take them up to the EML by the provinces. Okay, I'm finished right actually. So bottom line is that basically the conclusion, actually quality of healthcare is for me it's a basic human right. Okay, we should be looking to be advocates and support the EML process and fight to make sure that the message is on. But that requires multiple teamwork at all levels. We need people to help us make these good decisions, because otherwise we have people who are maybe not in the know making decisions for millions of patients. Thanks very much for the time.